Hi there. So this is my substance abuse presentation on fentanyl, and my name is Sydney Stivers. So introduction to fentanyl. Fentanyl is a synthetic opioid drug that is legally distributed in the United States as an analgesic and an anesthetic. It has the Food and Drug Administration's approval for such uses. However, it is often used and obtained illegally. It goes by several street names, including Apache, China Girl, Chinatown, King Ivory, Murder 8, Tango and Cash, amongst others. Fentanyl is a Schedule II narcotic. According to the literature, fentanyl is 50 to 100 times more powerful than morphine. It is also 50 times stronger than heroin. Fentanyl causes fatal overdoses in microscopic amounts. Fentanyl is highly addictive as it causes alterations in the reward systems of the brain, causing the consumer to continue use. Continued use leads to dependence and tolerance. Therefore, to avoid withdrawal, the individual must continue to use despite negative effects. Additionally, to experience the same effects, the user must use stronger doses over time, increasing the risk of overdose. So the history of fentanyl. Fentanyl was developed in 1959 by Dr. Paul Janssen. It was initially maintained for use in surgical procedures. However, in 1990, the transdermal patches appeared for the treatment of chronic pain. Fentanyl analogs are obtained unlawfully, reproduced versions of pharmaceutical-grade fentanyl, also referred to as designer drugs. Fentanyl analogs are chemically altered to evade classification as a controlled substance. According to the literature, from 1999 to 2011, opioid-related mortality quadrupled. However, from 2011 to 2013 is when overdose deaths surged. The timing of this aligned with the initial discovery of fentanyl being manufactured and redistributed illegally. Furthermore, in 2021 alone, there were approximately 71,000 opioid-related overdose deaths in the United States. So in terms of the prevalence and epidemiology of fentanyl in the United States, it began in the 1990s with the idea that pain was being undertreated. During this time, opioid prescribing skyrocketed and opioids became more widely available. As a result, the United States saw an uptick in opioid use disorder diagnoses. Initially, abuse of heroin erupted in the early 2000s as an alternative to prescription drugs due to its accessibility and low cost. However, around 2011, fentanyl use took over the market. As a result, the number of overdose deaths increased substantially as well. Furthermore, it is not that heroin users intentionally converted to fentanyl use. Rather, heroin producers began lacing the drug with fentanyl. Unbeknownst to users, the fentanyl-laced heroin was significantly more potent than their usual heroin, leading to a significant uptick in overdose deaths. The number of users who seek out fentanyl by itself is unknown. However, it has been observed that fentanyl overdose is much less reversible than overdoses where fentanyl was combined with another substance. Risk factors and vulnerable populations. According to the literature, there are several risk factors for fentanyl abuse. These include being an adolescent or young adult, current or past substance abuse history, underlying mental health conditions, social environments that promote use, and or family environments that encourage use or family history of substance abuse. Additionally, previous prescription opioid use may increase the likelihood of abuse. Furthermore, abuse has been more closely associated with those between the ages of 18 and 24, as well as those over 75 years old. Researchers speculate that the increased rate of overdose in the 18 to 24-year-old population is related to having been prescribed an initial opiate, paving the path for illicit use. Furthermore, researchers have found those of Hispanic or Asian descent to be at least risk for overdose, especially when compared to African Americans who display the highest risk. Additionally, comorbidities with a high degree of risk for overdose include cancer, cardiovascular disease, and diabetes. Psychiatric illnesses with the highest risk for overdose include depression and substance use disorder. In terms of short-term side effects of fentanyl, these include analgesia, euphoria, sedation, nausea and vomiting, dizziness, urinary retention, constricted pupils, and a reduced respiratory rate. However, in terms of long-term side effects of fentanyl abuse, these can include alterations in brain structure and function. These also include significant oxidative stress and inflammation in the cerebral cortex. Researchers have found that chronic fentanyl use may cause increased apoptosis in this region. These factors have been further correlated to negatively impact neural degeneration and white matter regions of the brain. Furthermore, chronic use is associated with decreased expression of the NMDA receptor subunits and dopamine receptors. Additionally, fentanyl use is subject to elevated levels of epidermal growth factor in the cerebral cortex. As this region of the brain is significant in reasoning and decision-making amongst other high-level functions, it can be understood why fentanyl is so highly addictive. So, signs and symptoms the provider wants to look out for on assessment in recognizing fentanyl abuse consist of making physical and behavioral observations, as well as observing for more advanced signs. Physical signs include weight loss, covering up arms with long sleeves, visible track marks, non-responsiveness, and/or pupillary constriction. Behavioral signs include changes in personality, poor attendance to responsibility, irritability or nervousness, and/or changes in hygiene. Advanced signs include losing or misplacing prescriptions, drug paraphernalia, and/or the possession of powdery substances. In assessing fentanyl overdose, the provider may observe pupillary constriction, stupor, diaphoresis, cyanosis, respiratory depression, and/or coma. According to the DEA, fentanyl overdose can be recognized in a triad of symptoms, including coma, pinpoint pupils, and respiratory depression. Potential for overdose or use as lethal means of suicide. As mentioned previously, fentanyl is dangerously potent, increasing the risk of overdose. Furthermore, researchers have found that suicide by fentanyl can be categorized according to varying intentions amongst users. These categories consist of accidental deaths, passive suicides, and active suicides. Accidental deaths occur because of overdose, which is most likely due to laced formulations of a drug. However, passive suicide by fentanyl occurs when an individual uses fentanyl or other opioids despite the risks associated with their use. These individuals are deemed to be careless in terms of their desires for life or death. Active suicide by fentanyl or other opioids is described as using a large enough dose of a substance with the intention of dying. According to the literature, it is estimated that approximately 7% of overdoses are due to active suicide. So an example plan of care for a patient abusing fentanyl or with opioid use disorder would be the following. So my example pharmacological treatment for this patient would be Suboxone 8 milligrams - 2 milligrams, sublingual film once daily for maintenance. This is, of course, once titrated at a clinic. And the rationale for this is that buprenorphine is indicated by the FDA for management of opioid use disorder. It is a less potent opioid agonist that assists individuals in eliminating use of more potent opioid substances, reducing the risk for overdose and death. Buprenorphine is combined with naloxone in a 4-to-1 ratio to make Suboxone. The combination of the two drugs reduces the risk for misuse as naloxone acts as an opioid antagonist. In terms of non-pharmacological treatment, I gave the example of cognitive behavioral therapy. Again, this would be a maintenance therapy. However, when combined with pharmacological methods, non-pharmacological modalities have shown to improve opioid use disorder recovery. Examples of non-pharmacological treatments include Narcotics Anonymous, inpatient or outpatient substance abuse treatment, and CBT. CBT has shown positive outcomes for patients with opioid use disorder. The goal of CBT with the patient would be to improve motivation for recovery maintenance. This would be done by examining and challenging current thought patterns, thus influencing behaviors. In terms of patient education, as an example in the case of Suboxone administration, the first education point would be that the patient should not swallow the film. Instead, place the film under the tongue until it dissolves. Having a sip of water before placing the film under your tongue may reduce the time it takes for the film to dissolve. If you miss a dose, take the dose as soon as possible unless it is close to the time of your next dose. It is important that you do not take 2 doses in one sitting. In addition, do not attempt to inject the drug as it will induce withdrawal symptoms. In terms of referrals, I would refer for cognitive behavioral therapy as evidenced by the benefits listed above. I would refer the patient for inpatient or outpatient substance abuse treatment depending on the patient's specific needs. Outpatient treatment offers flexibility and may include partial day treatment programs or outpatient clinics. Inpatient treatment offers around-the-clock supervision and is generally more intensive. On the slide here, I included a sample referral for buprenorphine treatment. So this would be in the case that I'd be referring the patient to a Suboxone clinic. In that case, this would be a good form to fill out. Schedule, so for follow-up, I would schedule a follow-up immediately after following treatment. The reason for this is continuity of care. So in conclusion, fentanyl is a powerful opioid with high rates of misuse. Its initial introduction into the medical field was as an analgesic or anesthetic used in surgical procedures. However, over the years, it was developed for transdermal use. In the 1990s, amid issues of pain control, there was an uptick in fentanyl prescribing. However, this inevitably led to the misuse and production of fentanyl analogs. As a result, fentanyl made its way into illicit substances, causing even further misuse, overdose, and death. Risk factors associated with fentanyl misuse vary by age and can occur because of pre-existing substance use disorder or the presence of underlying mental illness. Signs and symptoms of fentanyl use can be behavioral, physical, or advanced. These signs can assist in diagnosing and treating opioid use disorder, as well as in preventing overdose and death. Short-term side effects of the drug include analgesia, euphoria, sedation, and respiratory depression. Long-term side effects of fentanyl can cause changes in the structure and function of the cerebral cortex. Overdose via fentanyl can occur either unintentionally or intentionally. Unintentional overdoses occur because of drugs being laced with fentanyl. However, intentional overdoses occur when there is a desire to take enough of the drug to cause overdose and death. Unfortunately, it's noted that 7% of all opioid-related deaths are due to suicide. Initial treatment may include either an inpatient or outpatient substance abuse program, as well as initial Suboxone titration to offset withdrawal symptoms. Maintenance treatment may include a combination of medication such as Suboxone and psychotherapy such as CBT. These last couple of slides are just my references used for the creation of this presentation. And I thank you so much for listening.